All right, y'all ready? Shree's, he's sneaking in the back. We have a quorum present. First thing is, nobody, no people signed up to speak. And we have, the next thing is the approval of the minutes, if you all had a chance to do that.
Move approval of the minutes.
Got it? Discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Next thing is performance improvement reports. It doesn't require any action. PSI 90 update. Dr. Stevenson.
Good afternoon.
Your microphone?
My microphone is on, yes.
Okay.
Can everyone hear me? Okay, so let's go through the slides. Do I have it? I have it. There we go. So, so we will return again to our quality goal and our current results. So as we've discussed over the last several months, our quality goal is PSI 90, which is our risk-adjusted weighted measure of a variety of serious hospital-acquired conditions. Our performance continues to be fairly strong. As of a couple of days ago, this was our result. We're still well within goal being better than 1. And if you all recall, 1 means that we are performing as expected for the types of patients that we take care of on all of these different measures. So as of 2 days ago, we were 0.92 for the year. But I will tell you that this is a bit of a dynamic measure, or at least the process of getting to the measure is a bit of a dynamic process. And we actually have a couple of different computer programs that actually scan our medical record to identify cases that we then have to review to see whether or not they would meet. So in the initial look at this data, we had 4 cases for the month of July, which gave us that month score of 0.98. Unfortunately, the other program said that there were 5, so we had to spend some time working between the 2 programs to figure out which was correct and also to look at the case to see whether or not it would meet. And indeed, in final analysis, it did meet, but we only determined that a couple of days ago. So the actual number for July will actually be 1.14. So it's actually the first month where we have had more events than we would have anticipated since we identified basically the coding opportunities to improve this measure from the first quarter. So this is not necessarily a surprise because these events are uncommon, and the reason that groups like Leapfrog, for example, look at measures like PSIs over an 18-month or 2-year period is that they're that they're rare enough that to get a meaningful number, you do need to look over a fairly lengthy period of time. So to have 1 month that's a little bit above the line is about as surprising as having a month like April where we're massively below the line. There's going to be a significant amount of month-to-month variation, but what will be much more meaningful is when we have a 1-year number and then even more importantly a 2-year number to really see whether we're really succeeding. But I think on the whole we're definitely moving in the right direction. I think I'm hopeful that August will be back down again, but it was just one of those months. The next page just gives you a sense of where we stand. The one thing that changed was that we had one more postoperative sepsis, so I'm going to give you the next slide. So if you look at postoperative sepsis here, it was 3.93. With that additional postoperative sepsis, it's 4.72. And with this information, we've been keeping our eye on this postoperative sepsis issue for the entire year. Again, it's a very highly rated measure. And the sepsis individually are fairly rare, but I think now that we're pushing up even higher than we had anticipated and significantly higher than last year, I think this is now time, and we're going to charge the Quality Council to start digging deeply into the postoperative sepsis issue and seeing where our opportunities for improvement lie. So this is, again, really why we are looking at PSI 90 and other similar type measures, is to look at areas where we are not performing where we would anticipate performing as an organization, and targeting those things for improvement activities. Conversely, DVT and PE, which still remains significantly elevated, for which we do have an improvement program in place, that's a much lower weighted event in terms of harm than the sepsis, and there are a lot more events that are in that PSI 13 measure. So we were already pretty sure, just based on the fact that that represents a significant number of events, that was something that we need to look at. But now that we're getting on into the year and sepsis is still remaining out there as something where we're just not performing like we would like to perform, now it's time to take some action on that one.
Is it just surgery in general? Or
No. So there are some complexities here. So to say postoperative sepsis, one of the challenges that we've had is that, for example, bronchoscopy counts as surgery. Now that's actually changing October 1st, and let me lay it out a little broader. Okay, so endoscopy has never been an operation, but for some reason bronchoscopy is. It's a weirdness, and it does hit teaching hospitals a little bit harder than it does non-teaching hospitals, and it's a weirdness. So if you get admitted to All Saints, for example, and you've got gook in your respiratory tract and you're on the ventilator, somebody's going to order the nurse to do endotracheal suctioning. In a teaching hospital, we are much more likely to do bronchoscopy because it's probably a little bit more effective. It takes a little bit more time, but there's great educational value in teaching bronchoscopy in that way. So it's sort of like a win-win-win. You get a better suctioning than you would by just blindly sticking a catheter down the endotracheal tube, and you also you can see what's really going on down there, which is nice as well. And then thirdly, you get to teach trainees how to perform good bronchoscopy. So it really is an excellent thing to do, and widely teaching hospitals, whether you're talking about Johns Hopkins or John Peter Smith, perform a lot more ICU and bronchoscopy than we do. But it puts a lot of patients.
Attention please, code red, Trinity Springs dining room. Attention please, code red, Trinity Springs dining room. Attention please, code red, Trinity Springs dining room.
So anyway, it puts a lot more patients into the surgical category, in our teaching hospitals, and I'm sure that that teaching hospital upset about this issue is probably one of the things that has gotten this changed, is my suspicion. So, all right, questions about our PSI 90 results? Okay. So the second part of my presentation is to, is there more? Where's the rest of the slides? Well, I hate to go through things without the slides.
Can we get them?
Can we get them over there immediately?
We can take a small delay.
Anything else you want to ask me while we're waiting?
Hochberg's back there grinning. I mean, he's up to no good.
My team up there. Make sure we get everything prepared.
I know, right?
Speaking of your team, I saw a picture of you. I'll have to.
This is open. Yeah, this is open.
I don't know how all this works, but we'll get it.
You got it? It's sent?
I do have a question for you, though. With the new rule about how we can interact with the staff of the network, didn't Neil tell us that we weren't allowed to have these one-on-one conversations and? Because I wondered, after we met, did I break one of the rules? I met with Michael, Michael was on the phone, but I met with Rob to discuss the agenda mainly, but we went over the material. Is that okay? Now, I don't know.
I'll follow up with Neil. I was not a part of his conversation with you, but I'll certainly follow up. I think,
Yeah, it
obviously we
has-
want to comply with the Open Meetings Act, so
Do we have it now?
I'll find out.
Yeah,
Okay.
it didn't dawn on me till after I'd done it, and then I thought,
I think when we were talking to Neil, we
Okay.
made it clear that it didn't make sense.
Thank you.
That we couldn't talk. And I think the open directive was if we were talking, they wasn't making a recommendation. It wasn't like it was a meeting. I disagreed with his recommendation.
well, I had a brief conversation with Robert. Mr. Browder, he was just kind enough to be available, and I asked him if it was okay, and you did the right thing. You referred me to Neil. But number two, you said that nobody wants to be the test case to I guess, get the Attorney General's opinion. But why would you not want to be the test case? Is it,
There's an unknown, sir.
oh, but God knows the law's an unknown. I didn't say that. Okay, go on. I'm sorry.
Very good. So, it's been precisely 5 months since Dr. Hochberg became the Chief Clinical Officer, and I assumed the role of Interim Chief Quality Officer. And so, especially given that it's to the day anniversary, it seemed like a good time to sort of review what we've been doing and sort of give you a sense of, we've talked a little bit about the perspective that Michael and I have been bringing to the quality effort at JPS, and to sort of flesh that out for you a little bit and just give you a very high-level overview of some of the stuff that we're working on. So, as mentioned, on April 5th, Dr. Hochberg and I assumed our current roles. And so why do we want to do this now? Well, again, to lay out why we're doing what we're doing and what it is that we're doing because of that why. So our basic tenet and approach is to create and encourage a proactive, open environment, asking questions of why and how, so why things are happening and how they're happening, while building upon our previous successes. And of course, the past, and one great example of the past laying the foundation for our evolution forward, is that the PSI 90 goal, which has been very instrumental in driving things forward, like what I anticipate to be future Leapfrog performance, really does lay the foundation for our evolution forward as an organization. So this new role, these new roles for both of us have been an opportunity to assess, evaluate, and re-engage quality and safety at JPS generally. So I think I mentioned in this forum earlier on in my tenure what I think the best definition of quality healthcare is. And for me, it really is the guiding light, if you will, for everything that I'm trying to accomplish and that Michael and I are trying to accomplish together. So quality healthcare is the healthcare that one expects their own family to receive without requiring special arrangements to be made. And so that means instead of, hey, I'll call my friend at so-and-so and they'll take good care of you, it's go to our emergency department, you'll get great care. Have surgery.
Attention please, code red, all clear, Trinity Springs dining room. Attention please, code red, all clear, Trinity Springs dining room. Attention please, code red, all clear, Trinity Springs dining room.
So were they serving some type of flaming meal over there?
Absolutely.
I know Azealia just ran out, maybe.
I'm back. It was
Oh,
a drill.
okay,
It was a drill.
all right,
Okay.
sorry.
So, have surgery in our place, you'll get great care. Go to our clinic, you'll get great care. Be a patient in our hospital, you'll get great care. And you don't have to call your friend who's the chief of, medicine or, put together your own ICU team or anything like that. You're just going to get great care. And of course, there is no hospital in the United States or probably anywhere that can live up to that every single time, but it needs to always be there in our minds of what it is that we're trying to achieve, where the vulnerabilities have been dealt with, where our patient experience is outstanding, where our systems of care are phenomenal, so that we really don't have to worry. We can just send our friend or family member over and just know that it's going to be a great experience and that they're going to have great quality health care. So what are the big picture ways in which we want to accomplish this? Well, number one is really a relentless pursuit of our vulnerabilities, regardless of source or area. So anywhere where we identify gaps in our processes or in the execution of processes, we want to shore that up everywhere we can find it. Reducing variation is a major key element of improving the quality of healthcare. When we have great variability, it becomes difficult for groups to work in teams because people don't know they don't know the script, they don't know where they're going, and they have to try to make things up in a one-off way, and that kind of variability leads to gaps and difficulties. And one big area that I've been very interested in since I got into this role was to take the various things that regulatory agencies and others ask us to do, take them to heart, and to use those things to become the kind of organization that they want us to become. CMS, AHRQ, Leapfrog, Joint Commission, they want us to be a particular kind of place, and it's a kind of place that delivers phenomenal health care every single time. What frequently happens, and what a lot of organizations get into, because there's a lot of stakes behind these things, is that they want to make the measure look good, they want to make the survey look good, and all that sort of thing, but they haven't actually embraced the ask, the true ask, and consequently they end up building sort of Potemkin villages, if you will, where everything looks pretty as they walk past, but it's hollow, it's not real. And so what we want to become is the place where that is real, okay? And then partnerships, between providers and nursing, between support services and others, between executives and frontline staff to make all of these things happen. So our tactics. The first was really to revamp the Quality and Patient Safety Division, and I'll show you our current upper-level org chart, which will give you a sense of what our priorities are. Retool some of the key committees around the hospital, particularly patient safety and quality councils, which we've discussed in previous meetings, but others as well, and I'll show you a couple of the others that we're looking at. Increase ongoing physician, staff, and executive engagement in quality, safety, and accreditation efforts. So, when I first started going to root cause analysis meetings a few years ago, there would be maybe, you know, a director level person there, maybe one other physician, usually a bunch of nurses, and everybody worked really hard and wanted to get good results. But now what we have every time are you know, a collection of some of the most senior executives in the hospital, not only physicians and nurses who were involved, but also their leaders, and also the very often the service line chiefs of the service lines where the providers who were involved in whatever the event was. And the beauty of this is that it creates, when we identify something, it immediately can generalize out to the whole organization, because you have people with broad vision and broad scope in their work immediately there at the table, looking at the action plans and making sure that they're going to have that kind of broad impact. And I think you've seen some of that in some of the action plans that we presented. And then, you know, to sort of follow on from that, to use some of these specific cases to identify broader organizational vulnerabilities. For example, do we do handovers well, this kind of thing, to address, to stimulate broad change efforts that will actually have impact across the organization generally. Another major focus, and you've seen this and we've just discussed it in the context of PSI 90 and postoperative sepsis, that we are now, you know, very actively using quality and safety data to order our change priorities, to decide what's most important. And now, out of that particular measure, you can see that we've chosen DVT and PE prevention, and now probably addressing postoperative sepsis as areas where quality data has actually driven us to address particular items. And then using, again, back to the taking to heart what these organizations are asking us to do, to use regulatory standards and other required reporting measures to stimulate broad positive forward momentum for the organization, taking those things to heart. So this is our current org chart, redesigned org chart for the quality division. As Interim Chief Quality Officer, I report to Dr. Hochberg as Chief Clinical Officer. I'm supported ably by Sean Shelton, way over to my right. We have named a new Executive Director for Quality Operations and Implementation. That's Emily Gard, who should be starting on September the 30th. She's a very experienced and dynamic healthcare leader, deep background in quality, passion for quality, currently serving as System Chief Nursing Officer for Life Care. With the dissolving of Life Care, which is about to happen at the end of this month, she was available to us. Sri Adisamili, who's our Director of Clinical Quality, is remaining with us, and he is responsible for delivering the data on the PSI 90. So you have him to thank for that effort, as well as many, many other reporting requirements that he and his team take care of. Adele Cunningham is remaining in the position of the Director of Patient Safety and Regulatory Affairs. So she's responsible for the entire patient safety effort, and it's out of her group that the root cause analyses are performed, and that overall events are looked at, and so that remains a very, very high impact team. I'm going to skip over to one other person who's basically in place, which is our new Director of Performance Excellence. Jessie Thomas was recently promoted from the Manager of Patient Risk into this position. She's an experienced Lean Six Sigma black belt, highly passionate about healthcare and quality, and will be a huge impact player for us. Starting on Monday of next week is our brand new permanent Director of Infection Prevention, Chantal Besa. She's a fascinating person with an incredible background, originally a Congolese-trained physician, also worked later in her career as a nurse in France, so she's been on both sides of that line, interestingly. She's worked for both Médecins Sans Frontières as well as for the CDC, and she's coming to us from another hospital in the area where she's serving as Manager of Infection Prevention. Highly effective person, and we are very excited that she's going to be starting with us on Monday next week. In the middle is a new position, which is the Director of Environment of Care and Life Safety. So this position replaces the previous Director of District Safety, which was very much a fire prevention focused role. This is a much broader role that actually I designed in collaboration with Kenny Carr and Gary Scott from Support Services and Clinical Engineering. And the goal of this position really is to fully understand all of the regulatory requirements that are involved with all of the non-clinical activities of this organization, and to engage with those teams to provide performance improvement assistance for all these non-clinical areas. And these are really they're really the biggest parts of the TJC book. And so the goal here really is to have an individual who will passionately drive us towards an environment where we have an environment that is absolutely safe for our patients to receive care, for our visitors and families to visit, for our employees and others to work. We have identified a phenomenal individual who's coming to us from the THR system, Melissa Kyle, who is a certified health safety professional, certified health system construction professional, certified health system manager, and a certified healthcare emergency management professional. So, phenomenally well-qualified individual and a dynamic personality to boot. So we are really excited, and she's coming next month. So we've talked before in this committee, and I thought it would be important to revisit again sort of the buckets of items where we see when we look and identify our various vulnerabilities, where they lie. And there are really 6. One are things that come up in situational communication. So we don't communicate in the context of a healthcare situation in a way that is as effective as it should be. So that's one area of potential vulnerability. One is, if there is a situation, does it get escalated to the people who can actually affect the right outcome? Do we transition care from one person to another in a way in which is as effective as it should be? And does that happen all the time? Are our clinical processes tight? In other words, have we designed things where our team members are set up for success, or where they're set up to struggle to succeed? If we have a good process, do we hold ourselves accountable to follow it? So do we allow deviation away from whatever the process is that we've designed? And finally, have we made sure that everybody involved in the situation, has what they need to execute it appropriately? So have we established our competencies, or have we helped provide training to make sure that people are competent in everything that they're doing? Do they know the clinical processes, for example? So that would be an example of an issue of competency. So we have reformed a variety of committees, or in the process of reforming a variety of committees. We've talked about Quality and Safety Council. So just to remind the group, Quality Council's job is to review our quality data and to identify priorities for quality improvement efforts, and then to launch work groups to address those priorities, and then to get feedback from those work groups to make sure that we're actually delivering on those quality improvement efforts. Patient Safety Council kind of similarly takes a look at events and asks, are there things that we need to be, reviews our action plans from the root cause analyses from serious safety events and sentinel events, and looks to see whether or not there needs to be initiatives done out of those action plans that could be best coordinated by a high-level committee like Patient Safety Council, and then once again launches work groups to begin to address those things. In the same measure, we're actually retooling Pharmacy and Therapeutics Committee to a significant degree to sort of adjust the membership as well as its focus to make it more focused on issues of quality and value for our organization, to make sure that the things that we're bringing into the organization from the standpoint of therapeutics in general are things that are going to help our patients have better health. And hopefully at also with a strong assessment of value as well. And then Moderate Sedation Committee, we're in the process of retooling that as well to make sure that we are really identifying all the events that happen there and make sure that our processes around moderate sedation are tight. We've also formed a new high-risk surgery committee. This is one of those things where somebody on the outside has asked us to do something. So in this case, Leapfrog thinks it's a really good idea for us to have appropriateness criteria for certain major surgical procedures like mitral valve replacement, carotid endarterectomy, open aortic procedures, and thinks that patients who are having big cancer operations like pancreas or esophagus or rectum or lung are being discussed at a multidisciplinary committee, which is very appropriate. So our high-risk surgery committee is tasked with two things. One is to make sure that when those kinds of procedures have happened, that they followed the appropriate risk criteria and then feed back to the surgeon to say, hey, actually this didn't quite meet, what's going on here. And then the second is, and then part B of that is to make sure that our, patients who are gonna have pancreatic duodenectomy for Whipple, for pancreatic cancer or a major lung resection, that those cases have been discussed in a multidisciplinary committee, which we have as well in multidisciplinary tumor board. And then the second is that when a surgeon or referring physician has a patient who, is by a variety of risk assessment tools, and we have the NISQIP one here in active use, when the risk of a particular procedure appears to be high, to have a forum, to have almost an ethics committee type discussion about whether or not that case should go forward from a medical standpoint. Not so much from an ethical standpoint, but to review everything to help the surgeon deal with the risk-benefit analysis and give the surgeon guidance as to whether or not to proceed. And that obviously is not true for hyper-emergency conditions, but if you've got somebody who's got, very bad COPD and heart disease and we're trying to decide whether they should have a hip replacement or something, it's a great place to have that discussion where you can see whether the risk-benefit tilts in favor of or against doing something. And it provides the surgeon, some backing as well if they're getting pressure from families or referring physicians to say, really, we've discussed this in a multidisciplinary format, and really the judgment is that it's not appropriate to proceed. Or conversely, no, it looked okay, you can go ahead. And then you've had a discussion, and so if the patient has issues postoperatively, you can say, well, we talked about it, A. And B, the other thing is that in this committee we have pulmonary and cardiology, and so if we decide we go ahead, we've already got buy-in from those specialties to help us manage the patients so that we can try to get them the best outcome they possibly can have.
Good.
So, so as we go ahead, as we've gone forward and looked at our vulnerabilities, we've identified a whole series, we've gotten into just an incredible number of projects, which are all either done or well underway to try to deal with these vulnerabilities. And some of these you probably heard about, like how we've improved our processes for high suicide risk patients in the ED. We're working on basically a way of dealing with patients with acute behavioral health issues now on the inpatient side, because the work on the ED sort of focused us on the issue in general for the hospital. So we're in the middle of getting meetings together to discuss going forward with what is really best practice in terms of dealing with behavioral health in the ED. Agitation order set is part of that as well, which has been huge, which the behavioral health group has really helped the organization with, but Quality has a hand in it. Talking about ways of improving our phlebotomy methods in high acuity care, improving ED throughput, escalation in labor and delivery, high flow insufflation for laparoscopy, RF sponges, MRI safety, pre-procedural huddles. So this is an expansion of the perioperative huddle to other procedural situations. We have a task force on handoff and handover, another task force on peri-procedural anticoagulation management. We're looking at retooling endoscopy completely, improving care for patients who are NPO in terms of better signage and explanation so patients' families know what the patient's supposed to be doing, making safety call better. That's a very active piece of work this week especially.
What is that exactly?
What's safety call? So every day, almost every department of this hospital has to report in to the whole group on a very large conference call to talk about safety issues going on in their areas. And so I would say that its first benefit was and it's been going on now for about a year and a half. Laura Burnside was sort of the original energy behind the project and remains very, very connected to the safety call. I think, it was absolutely an amazing tool, I think, when it was first introduced, in terms of just bringing the whole hospital together for the first time on a daily basis, so everybody feels together. And a lot of the information on the call is pretty useful, but some of the information we've kind of sorted out maybe isn't so useful. It's kind of rote and repetitive, so we're just looking at ways to kind of energize it a little bit more and make it a very, very high impact call. And the other thing we've done is, as of this coming weekend, it's going to be 7 days a week. So it's been Monday to Friday since its inception, and now it'll be 7 days a week because, of course, quality and safety are an everyday job. So, and then we've been working on high-level disinfection as well, which is, of course, an area of national interest. Regarding quality measures, we have obviously a continuous examination of falls, and actually falls data has been improving over the course of the year thanks to these efforts, but we're also looking at whether new beds may be able to reduce falls, and there's some evidence to believe that that is true. As those of you who've been on the committee for a little while know, we've been looking at colon SSI for a while. This has stimulated changes in perioperative blood glucose management, as well as an enhanced recovery after surgery program for colon surgery. Those things have both been pretty successful, and for the first time, our SIR, which is the ratio of observed to expected for our colon surgery population, has gone under 2 for the first time. So even though it fell off the goals, it's been an area of continuous look, and getting under 2 is not insignificant for a hospital like ours. You say, well, that still means we're at 1.69, you're 69% above expected. Well, yes, but we do have some challenges, and the challenge is that when you look at our 225 to 250 colon operations we do each year here, only about 93 are done on outpatients coming in for elective colon surgery. So we do have, we are highly enriched in colon surgery coming out of the emergency department, and those patients are higher risk. So it's going to be tough for us to get under 1, but I am very pleased that we are definitely moving in the right direction. Hysterectomy SSI has been an amazing story. With the addition of metronidazole and getting buy-in from all the gynecologists on hysterectomy perioperative prophylaxis, that harm event has essentially disappeared since it has disappeared. We have not seen hysterectomy SSI since last fall, at least not one that's organ-space. So that's really a remarkable accomplishment. Based on some data we've seen in our total joint program, we've taken a whole new look at OR cleaning and preventative maintenance for HVAC. We're looking at sort of the right approaches for bathing and pericare under CODI.
What's HVAC?
Oh, sorry, heating, ventilation, and air conditioning.
Good.
So, but Kenny and Gary have this guy named, director named Omar, who is a absolute master of HVAC, and he is retooling everything. Under CLABSI, there are a bunch of things going on to try to further reduce central line infections, and actually our results in that remain fairly good, but could be better. So we've discovered that a lot of these infections are happening in patients with dialysis catheters who've had them for a long time. So we're in the process of launching a peritoneal dialysis program, and we're also trying to increase the number of patients who get sooner to surgical hemodialysis access. And in addition to that, we're improving hemodialysis catheter care by kind of focusing that in the dialysis unit, and we now have the right bio patches and all that stuff, so we're really hoping to see some movement there.
Good.
And as I've mentioned before, we've got a work task force going on in DVT and PE mitigation, risk stratification and standardization. Some of our priority initiatives under Leapfrog, and you're going to hear, this is an advertisement for November, but we'll be coming to you in November with data and action plans around hand hygiene. At one level, the data looks really, really good on hand hygiene, so it's been an area of focus here for some time. But Leapfrog actually asks us to bring this data to the board and our action plans. And, in the spirit of taking this to heart, why do they ask us to do this? Because there is absolutely nothing that we can do that is more important in infection prevention in a healthcare setting than having outstanding hand hygiene. There is nothing more important, and this is known by the Leapfrog people, so they want to see us take it seriously and bring it to your attention, exactly what we're doing about these things. Similarly, in the spring, we conducted the Leapfrog required AHRQ culture of patient safety survey, and it is and just like the hand hygiene, they want us to have high-level buy-in at an executive level around the results of this survey, to design processes that will improve the culture of safety, and then bring it to you to show you so that you can have oversight over what we're doing in this regard. Why does this matter? Why does this survey matter? Well, there was a really nice paper in the Journal of the American College of Surgeons actually in the last month, which showed that hospitals with higher scores on this particular survey have fewer surgical complications. So there's actually this is now a very clearly demonstrated relationship between our results in this area and our outcomes for our patients. So it's critical that we take the results of this survey seriously and look at ways to improve. And if we do, it's going to be better for our patients, so we've got to do it. And again, this is something that the Leapfrog people know, and so they want to see us take it seriously, so they want the executives to be involved, and they want our board to also be aware of what we're doing and approve of what we're doing. And then, as well, I mentioned this, the high-risk surgery committee earlier. And then in terms of our regulatory compliance and how we're trying to drive that forward, well, this is the motivation for having created the position of Director of Environmental Care and Life Safety, so that we have in-house the expertise we need to try to make this environment the right environment for our patients, families, and employees. So that's the end of my presentation. If any of you have any questions, I'd be happy to entertain them.
You can start all over again.
You've got a lot of work going on.
It's a big hospital. It's a big health network. We got a lot to do.
Yeah. No, I look forward to seeing the evolution and the outcomes, for sure.
When you-
Dorothy, go ahead.
When you're looking at the colon SSI, and you're saying a lot of them are coming through the emergency room, are any of those our JPS connection that's been in our program and just have not been?
So the answer would be yes, some of them would be. Our penetration of screening is not what we would like to see, certainly. They're not all cancers, though. I mean, some of them have diverticular strictures, some of them have, once they get perforated or something, they're not really gonna fall into the SSI category, but one of the cases I can think of right off the top of my head was a patient who came in with a diverticular stricture and got surgery and subsequently got an infection. So, operating on obstructed colons, even if they're not perforated, you can't prep them. Because that would be, a certain form of torture. You're gonna be at a higher risk for getting an infection under those circumstances. So whenever you have a population that's enriched in what's coming through the ED, you can't do everything that you would do for somebody coming from home where you have, prepped the bowel, you've optimized them in terms of their comorbid conditions like diabetes, smoking, all those things we've gotten very serious about through our surgical optimization program. So that group of 90-something, they can all go through that and be made as perfect as possible. But when somebody comes in with some issue that needs to be managed in an urgent way surgically, your options are a lot more limited in terms of mitigating those risks.
Okay.
I don't look at it from prep versus unprep.
No.
It's all just
It's
the
a,
same thing.
it's, the only thing that gets, that excludes you is if there is infection present at the time of surgery. So if you operate on a perforated colon and there's stool and pus everywhere, that patient isn't going to be counted in the CMS reported number. But if, they just happen to be obstructed but not perforated, then they're still at higher risk, but they don't get excluded.
Okay.
So.
Would there be any value in just internally looking at both emergent and non-emergent and to see where we fall for the non-emergent?
So we have very, very few infections in patients like, I don't know if we've had one this year in a patient who came in from home. So our program on the elective side is very, very robust. So we might have had one. I wouldn't want to be absolutely held to that, but it's very low, yes.
How's it working from your standpoint, Brian?
So we're starting to use a
Total
lot of
joint.
the same program that, we're starting to use a lot of the same program that they've done for the colons to go through with our total joint program. And we've hired a nurse practitioner that's working on all of our patients to get them preoperatively medically managed and go through the optimization clinic here at the hospital. So a lot of the great successes they've had, we're starting to take over to the orthopedic side.
And they also have a fantastic joint class that all the patients are required to go through, so they're really well educated about their process. And it's a strong program, and I think we're beginning to see some good results from it. So,
That's a pre-op program?
Pre-op.
Awesome. No, a lot of good things going on. Many good things. Is the Leapfrog data that we report to them, are we still about a year and a half, year behind?
so it's
Am I asking the question properly?
so it's complicated. Most of those lagging metrics are actually pulled metrics. So it's not stuff that we report. It's stuff that actually comes out of our coding data that they're pulling, that CMS is pulling out of us, and then Leapfrog uses that CMS data. Okay. But it depends on the measures. A big chunk of Leapfrog is about stuff that we're doing, and that we have to tell them whether we're doing or not. And if they come and audit us, we better have been doing it. So, there's a lot of accountability around that. So that's stuff like whether or not we're presenting our hand hygiene stuff to you. So that there's a big category of stuff that's that. Then there are some things that then there's a bunch of stuff that's pulled metrics. Like, for example, our results on HCAP surveys. So we're doing it, but that data is being pulled up by CMS. They're looking at it and then they're reporting it. That stuff isn't that delayed. That's maybe 6 months to a year, at most a year and a half behind. So, you know, if you're doing your fall survey, you're probably looking at 2018 data. So fall 19 survey would be probably 2018 data. And then for these PSIs, which are much less common, so if somebody, we were talking about postoperative respiratory failure, postoperative sepsis, especially those two, but all of them are sort of lumped into this, then we're looking at data that is roughly 12 months old to roughly, 36 months old, something like that. So or 27 months old, or something in that range, 30 months old. So they wait for a period of time to make sure that what they're collecting is accurate, and then they report a fairly long interval to make sure that the little bumps of the incidence of these things, because they're relatively uncommon, get kind of smoothed out by a fairly long time interval. So there are a variety of different time frames, but I mean, I think the most important way to think about Leapfrog is that to really perform well on it, it requires sustained effort. So you can't just give a 6-month effort and expect your score to move very much. It's got to be something you're really on year after year after year after year.
The Leapfrog score was one of our measures, and I assume it will be one for the future as well. You mentioned how hand washing is so critical, and I agree. But I'm going to call on Reverend Ralph Waldo Emerson here to tell a little story that he told the whole board about hand washing. You remember? You were visiting one of your people in the hospital.
The story is that I went into hospital up the street, and they were in isolation, and told me I had to wash my hands, put on the gown, everything, and before I went in. And I did all of that. But the nurse comes up and says, "Oh, I'm not going to be in there long." She rushed in, did what she needed to do, and left. So I did what I didn't have to do long. I called somebody on the spot.
Just tell one little deviation. It's going to run into a room without washing your hands.
Exactly right. Well, if you'll forgive me a very bad analogy, but I like to, this is how I teach hand hygiene to my residents.
Is this going to terrify me?
No.
Oh, okay.
Might terrify the legal counsel, however, but not in any bad way. But the way I teach hand hygiene is that to my surgical residents is that I say, you know, so let's say you did surgery on a patient a couple of weeks ago. You did some sort of open abdominal surgery, and they come back a couple of weeks later with abdominal pain, and somebody gets an X-ray, and they put up the X-ray, and there's this big white thing sitting in the middle of the abdomen. And I said, "What is that in the abdomen?" "Sir, that sounds like a malleable retractor, sir." I'm like, "Yeah, that's what that would be." "Is that a bad thing to have happen?" "That's a very bad thing to have happen, sir, yes." "Okay. Is there likely, is that going to get people in trouble?" "Yeah, it's going to get people in trouble." "Okay." And I say to them, so that bothers you a lot, right? And they said, "Yes." But I said, "Is anybody likely to die from that?" And the answer is no. You just have surgery and take it out. Like, okay. But it bothers us because we can see it very clearly with our eyes. It's very bothersome to see when we see that. And, but it's not, it's a bad thing, but it's not dangerous in the way that some other things are. I said, well, okay, so what if you go from patient A to patient B and you don't wash your hands? Now, you can't see anything on an X-ray about what you took from patient A to patient B. But can somebody die because you did that? Absolutely. So every single time, you need to wash your hands. Every single time. And that's how that's my extreme way of teaching it. So I beg the board's, the committee's indulgence for that, so.
That's good. Did it terrify you?
No, sir.
It would have terrified you if you were a defense counsel for the, for the surgeon.
All righty. Any other questions, comments for Rob? Amanda, any? All righty. Good,
Okay,
good work.
thank you, sir.
That is all that I have for open session. We have a little bit to discuss in closed session. We could take about a 5-minute break. We'll reconvene in executive session pursuant to Chapter 551 Texas Government Code.